Starting. Good morning to everyone, and today's topic is on principles of amputation. Screen. And today's topic of discussion is on nomenclature and history of amputations and the definition of amputation, goals of amputation, and the principles of amputation. About the history of amputation, basically the word amputation was derived from the Latin word, which basically means to cut away. And amputation is the most ancient surgical procedure. We have a myth which means amputation is a procedure which was done later when the treatment of medical treatment was failed. But actually, it is not. Amputation is not the next step to the failure of the treatment. Basically, we are trying to improvise the patient and get the patient as early as possible to his normal life. And the word amputation was basically derived from by Hippocrates, and the first person to introduce ligature was Hippocrates. And the importance of ligature was to control the hemostasis, which was the most common complication after the amputation. And Ambroise was the person who introduced the artery forceps to hold the blood vessels and to control the bleeding intraoperatively. And amputation is defined as a removal of a diseased protruding functional unit of the body. Amputation is a definition which defines the surgical removal or a loss of a limb through one or more bones. And when compared with the disarticulation, which is a surgical removal or a loss of limb through a joint. Most commonly, these amputations were common in males and most commonly in the lower limbs. And 70% of the time, amputations were basically because of trauma and followed by peripheral vascular diseases. And the causes of amputations are congenital, traumatic, vascular, and neoplastic and infections. In trauma, most of the time, railroad accidents and war and industrial, mostly these amputations were developed post World War II. And goals and objectives of amputation is mainly the preservation of life post-trauma and preservation of function when there is a peripheral vascular disease. We will try to preserve the function. There are two things. When we are preserving the function, we'll try to amputate as distal as possible. And with the distal amputations, there is a high chances of complications. And when with the proximal amputations, there will be minimal complications, but preservation of function will be minimal. So when we are going for an amputations, we'll consider both complications and function preservation. So it is one of the main objective of amputations, and early return to function and minimizing the energy expenditure and preservation of limb and preservation of adjacent joint contractures. And our determination of at which level the amputation to be done by the zone of injury, because during the trauma we can externally see the wound and decide at which level we can do the amputation. But in the peripheral vascular diseases, with the injury or the trauma or the disease is internally, so intraoperatively we'll decide at what level the amputation should be. And adequate margins is necessary when we are doing the amputation because of tumors of the bones like osteosarcoma. And adequate circulation is the primary requirement during amputation, because if the peripheral vascular disease was still above the level of amputation, again a redo amputations may require. And the soft tissue envelope to provide a good cushion for the stump, so that the prosthesis will be arranged safely and it will be prolonged. And the condition of the joint, which is proximal to the stump, so that the level of movement of the joint at the proximal level is also important, and to control the infection, because if the patient is in diabetic, is high level of sugars were there, the complications further, and nutritional status to better healing. And the principles of amputation during the intra-op period, mostly for the amputation at the level of skin, muscle, nerves, and hemostasis and bone are required. At the level of skin, the mainly the size of the flap should be generally 1.5 times of the width of the amputation level, and these flaps should be so thick so that the vasculature generally which comes from the deeper areas should be preserved, particularly in peripheral vascular disease, where already the vasculature is compromised. If you go for a thin flaps, there is a definitely post-operative necrosis. So a particular level of flap thickness is required, and the suture should be with a minimal tension, so that which leads to necrosis post-operatively. And the main important thing is that post-operative healing, which leads to a scar, it should be painless, non-adherent, and pliable, so that when the prosthetics are used in the particularly in the lower limbs, these if the scar is tender, the patient may avoid these prosthetics because of pain, and he can't transfer the weight. And during the muscle cutting, basically around 5 centimeters distal to the bone, we are importantly talking about the fixation of the muscle distally at the amputation level, because if you do not do the proper muscle fixation, it may lead to the atrophy of the muscle, and the stump might become thin, and the bone become more prominent, and the cushion will be lost, which leads to again the prosthetics cannot be fitted properly, and leads to pain during the weight bearing. So there are 4 types of muscle fixation, of which in the first type, myofascial closure, we fix the muscle to the fascia, and in myoplasty we fix the muscle to the opposite side of the bone, and in myodesis we fix directly to the bone, and in tenodesis we fix the tendon to the bone. Most commonly we do is the myodesis. In myoplasty, there is a movement of muscle during the motion, so there will be unbalanced movements during the if the fixation is myoplasty. So the most commonly used one is a myodesis, and in ischemic amputations, generally avoid myodesis because it may lead to compromised blood vasculature to the amputated part of the limb. In non-ischemic limb amputations, generally the flaps will be anterior and posterior flaps will be almost equal, because blood vasculature will be almost good in non-ischemic limb fractures, and in ischemic limb fractures there is a smaller anterior flap and a large posterior flap, because in the studies most commonly the anterior flap is the one which is gets necrosed post-operatively. Here in the ischemic limb, yes sir. Yes sir. Generally anterior classically, surgeons evaluate for before closure mainly for color, consistency, contractions, and circulation, because the main thing is the circulation, which will by the which we decide the color, and consistency, which decide that the tissue which we debrided is after the debridement is good for healing or not. And traumatic amputations can be left open for serial debridements when primary amputations primary closure cannot be done. This is the most important thing in the amputations because this is the most common reason for the mortality in the initial days of amputation. In the initial days, they used hot oil for stopping the blade, which is a crude thing. So as age progressed, as I said, Hippocrates developed the tourniquet. He is which is the ideal one. Even now we are using for the amputations. Only for the ischemic limbs we don't use tourniquets. And before applying the tourniquet, we'll drain off all the blood from the lower limbs by elevating or wrapping up a bandage and inflating it. And the only contraindications were infections and malignancy, because these miss chances of spread of infection and malignancy. So in these situations, we will only elevate the limb for 5 minutes before applying the tourniquet. In amputation, mostly the blood vessels should be ligated and isolated and ligated most of the times, and as much as possible avoid cauterization. And when there is a major veins and arteries together, you should not do ligation together, and we should separate, isolate it, each artery and vein separately, and we have to double ligate and then cut it. And the tourniquet should be removed before closing the wound, because if there is any active bleed, then immediately we should stop and we can go for a closing. And we have to keep it drain for at least 2 to 3 days in a major amputations like lower limbs. And size of the tourniquet should be generally 10 centimeters to 15 centimeters when compared. If it is the thicker legs, we can go for a larger size. And the site should be generally in the upper areas of arm or in the upper areas of a thigh. Wool protection before applying the tourniquet, and pressure should be at least 50 to 100 mm in the upper limbs, and 2 times the systolic blood pressure in the lower limbs. And time of maximum of around 3 hours can be applied, but generally only 2 hours will be used. And we should monitor and document the duration and pressure which we are applying. Maximum of 3 hours we can apply the tourniquet. Once we remove the complete sensation and everything will come back by 5 to 6 days. Orthopedic the website. Yeah, that's what I mean. I'll check it 1 second. And because of if it is maximally, go for 3 hours. If it is greater than 3 hours, it is irreversible. Massive I'll check it. Yes. Yes. And after the amputation of nerves, the most time the amputation after the amputation, the doctors are more concerned with the formation of neuromas from the distal end of the nerve fibers, because the axons which were amputated cannot identify the distal end of the nerve. So they keep on continually multiplying and forms a neuroma, which when it is in the part of amputated area and the stump area, this when they have applied the pressure or pressure over that area because of prosthetic. These develop pain, and this again leads to compromise in the weight bearing of the patient. So as techniques develop, they have started giving the traction to that nerve and cutting a little further so that the stump, the nerve ending should not come into the stump. But whatever they tried, the neuroma formation is inevitable. They have tried things like applying the pressure and keeping forming the endoloop anastomosis and applying a caps and a ligation and cauterization and burying into the bone. But still the neuroma formation is inevitable. And there are techniques. They will connect to the now. Yes, sir. They will isolate and gently pull distally into the wound and divide cleanly with a sharp knife so that the proximal end, end should not come into the stump area. Bones are sharply divided, and we will the sharp end should be definitely be beveled or filled so that the sharp end should not be present. So the bone end should be soft so that the prosthetic should be fitting so without causing any pain. And if you leave the condyles or metaphyseal flares, it may lead to the larger stump, and it may require a further larger prosthetic, and it may lead to the cosmetic compromise for the patient. And most of the surgeons will do periosteal stripping to prevent the bone growth. So it is also to avoid over stripping of the bone. And in distal limbs, when we are doing the amputations, the distal fibular end, it should be 1 centimeter smaller than the tibial end, because this fibular end will start again give the pricking sensations and in that area, and leads to the prosthetic compromise and decrease in weight bearing. And when there is because of biceps femoris, which is a strong muscle of quadriceps, which leads to genu valgums in the chronic periods. And types of amputations. There are two types, which are open and closed. Open are galeton and modified galeton, in which we amputate the leg and we will wait for a few days so that the infection, whatever after the trauma, we'll wait for the wound to heal properly, and then we'll go for closer secondary or planned surgeries, which are galeton and modified galeton. In galeton, we amputate at a sharp end so that the skin and the muscle and the bone all are at the same level. In a modified galeton, we provide the muscle, the skin level, so that with the flap, so that in the secondary revision surgery, there will be direct closure of the stump without any, again, Rudy surgery without skin flaps. In the closure surgeries, it's a planned surgeries in which we do the regular procedures. When we are going for an open, we will do a revised surgeries and a planned routine surgeries. Levels of amputations in the lower limbs is around hip and in the around knee. In the knee, 12 centimeters proximal to the knee in the above knee amputations, and 14 centimeters below the knee in the below knee amputations. And most commonly, general surgeons will do foot and ankle amputations, which mostly will do your toe amputations and toe articulations, disarticulations, and transmetatarsal, Chopard's, Lisfrenac, and Syme amputations. In Syme, we do around 0.6 centimeters proximal to the ankle joint. And modified Symes, we do around 1.2, 1.5 centimeters proximal to this ankle joint. In Chopard's, we'll disarticulate in between calcaneo-cuboidal joint and talonavicular joint. And in Lisfrenac, we disarticulate the transmetatarsal joints. In transmetatarsal, we'll go in between the metatarsals. And in amputations, based on the level of requirement, we'll go for amputations in the toes. And in re-amputation, we'll do amputation of a toe along with the head of the metatarsal. Continue, sir. As I said, when there is a distal end is little large, like a bulbous thing, so there will be requirement of special socket designs, because most of the prosthetics will contain the sockets which are narrower, so that the cosmetically it will be good. And complications of amputations: hematoma, infections, necrosis, contractures, painful neuromas, and phantom limbs. To prevent the hematoma, we should go for a meticulous hemostasis intraoperatively, and when there is a hematoma formation post-operatively, you should drain it off immediately, and then better to keep a drain when there is a suspicion for hematoma. In infections, we should provide hygiene, high level of sterile conditions during the operation, and control the infection as much as possible pre-operatively, and remove the tissue, dead tissue and infected tissue as much as possible intraoperatively, and control the comorbidities like chance for infection, which will be increased. And to avoid necrosis, the flap should be so adequately thick, so that the blood supply is quite almost equal to the normal tissue, and the skin flap should be closed in such a way that the tension should be minimal, which because it may lead to the necrosis again. And painful neuromas, as I said, intraoperatively, we should cut the proximal nerve fiber, so that the stump, it should not come into the stump area. And phantom limbs, we can be treat by giving stump bandings and stump exercises and following. Yes. One thing is vasculature is important, so that yes, sir. So one thing is when there is a joint infection to the joint, definitely we go further proximal end. So we'll go for a reamputation. And one more is the vasculature also increases because of the marrow which we are exposing out.
One is that the value will be lesser. So if there is then this case may become to avoid that, you have to use the state of getting you in this case, what I
That's right. Increases.
And any disadvantage, anytime disadvantage goes on, always have to either cut the articles or just or have to copy the articles. It's why the articles because it's one green. And that itself.
So even in normal disarticulation, we have to cauterize. Ideal stump length of the stump should be adequate. As I said, if the in the mostly in the lower limbs, when there is a we are more thinking about the functional in a functional way, so that the weight bearing will be adequate. We should go for a long length. And when we are thinking of a patient who has old age and who is already bedridden, we can go for proximal amputations, because it has minimal complications. And muscle power should be good in the stump and proximal joint. As I said, if you are not using the muscle, it may go to the atrophy. So when we are not fixing the muscle properly to the lower end, so that there is no contractions even with adequate force by the patient, so it may go for the atrophy, and later it leads to thin stump, and which leads to improper weight bearing. And there should be a full rotation of movement in the proximal joint and healthy and non-adherent cast, so the prosthetics will fit properly, and normal skin sensations and no neurons. And we call a bad stump when the size of the stump is small and inadequate in size, and the musculature, as I said in myoplasty, the musculature will move around the stump, so it will be flappy, and it doesn't help in good prosthetic weight bearing. And the bony stump, as it is, it leads to a pain in the stump, and it will when the weight bearing is done, the pain will be more, and there is a restriction in the rotation of movement at the proximal joint and presence of neuromas. And post-operative goals: adequate wound healing, that means early wound healing and a pain control, and preparation of residual limb for the prosthetic fitting. And there is a minimum of rotation of movement at the proximal joint level, and there should be independent mobility for the patient, and support of for adaptations to changes from the amputation. And difference between dysvascular and traumatic amputations. Traumatic wounds usually are acute presentations. When they come to the patient, we can decide whether at what level the amputation, because we can see what till what level the wound has been damaged. So we can go for the amputation. We can decide at what level of amputation in the pre-operative itself. But in the dysvascular, like peripheral vascular disease, it's a chronic presentation, and the compromise will be in the internally. We can't decide by seeing pre-operatively, and we can't decide at what level the amputation is. So it has to be explained to the patient, and we have to take decision for the amputation intraoperatively. And there is a requirement vascular surgery in the when there is a vascular compromise. In the traumatic wounds, as it is an emergency, we can't wait for rehabilitative benefits post-operatively. So we have to go for immediate amputations, because patients' life is more important than post-operative thinking. And in vascular compromise, usually we'll manage as much as possible with medically, and then we can plan amputation with the post-operative benefits for the patient. And as I said before, a tourniquet is generally applied for every amputations except for the ischemic amputations, as a vascular compromise and ischemic vascular compromise. There is an ischemic part, so we can't apply the tourniquets in this area. And we generally go for a long posterior mycotinous flaps in the vascular compromised amputations, and the reconstructive flaps are usually not helpful in dysvascular amputations, because already the vasculature is compromised. And in the post-operative period, limb elevation is controversial in vascular compromised amputations, because already the vasculature is compromised, and we are giving again against the gravity, which leads to compromise again the vasculature to the particular area. And compressive dressings are not recommended, as these dressings itself causes the compromise in the blood flow. And there might be requirement for anticoagulants and vasodilators for amputations which are in because of already the vasculature is compromised, so it helps in increasing the blood flow to that particular area. RTA, yes.
But anyways, for the sake of discussion, okay, but then nowadays all traumatic amputation is doing that. So no amputation is related to the requires development at the level. But the implantation is a lot of implantation. Even after the distal implantation is job. There also can be implantation. So if you find that that is not there because of this angled or touch, then you not then you are doing everything. But not all implantation require closure. They can be
Yes.
including the vascular and the both can be impaired and which can function level. So, you know, I can wait can be impaired for the sake of
Processor generally helpful for replacing the missile limbs and to restore as much as normal function of the for the patient. Basically, it contains sockets, suspension, joints, and base. And these are classified into endoprosthesis and exoprosthesis. These endoprostheses are in these implants were fixed to the bone. Mostly, these are used in orthopedics. And in exoprosthesis, these are external replacements in which socket is the most important thing. They can be removed and refixed again. These are lower limb prostheses, ankle level and foot level. And at the ankle level, there are two types basing on the mobility of the joint in the prosthesis. Those are non-articulated and articulated. Non-articulated are Jaipur foot and Madras foot. In articulated, there are single axis and multi-axis. In the articulated, the single axis will provide only in one axis the movement. In multi-axial, there will be multiple axis movements. So it compared with the single axis, multiple axis has a better better prosthetic importance. And in compared with the Jaipur foot and Sac foot, this Jaipur foot is developed in India, and it is cheaper compared with the Sac foot, and it has better dorsiflexion compared with the Sac foot. So, and it has cosmetically almost similar to the normal foot when compared with the Sac foot. So it can be used as a in the barefoot also. And as it has dorsiflexion, sitting and squatting can be possible with the Jaipur foots. And recent advancements are like myoelectric processes. These processes are advanced, like they will detect the signals from the stump area now endings, and they will process it, and then they will activate the movements in the prosthetics. Thank you.
Fingers are this is where not 11 0 here 10 0 from here 9 0. So here are 7 0. Which absolutely one artery is not compulsory, and I think so one artery and two veins also. And now this regular part and there is a lot of question generally, but the amputation will never be straight up. We have question and we'll have to revise them to the limit and shorter. So remove press, remove all the cross and all the all of them mark and this part are the one thing is when then you first bonus one experience, then start. Rather than the next one, it's going to be so 6 hours and period for the average. More the muscular component of the anterior storm in the center is the muscles can tolerate very less. So if the amputation from high level, then the systematic is something that's less than 4 levels, 5 levels. Then the amputation starts from the finger, you can even make it to another. So there's no muscle here, the main temper. So it's made up of high. That's all this systematic all these ways. Never, even others. Even others. Others, when you just go down. Because this can move and then is not better than and sometimes most of the other thing of things normally mainly at any point of time, you won't actually win the market. So, another possibility you have to sort of and mainly the amputation, you have to look for only that amputation the strong line. That is the most important for that you are in variable and what then so that must be required for the lesser than that must not enough strength the lever is not there to the process but that's on the different that potential the final star line where are you going to start? So for the exam purpose, all of it is fine to make knowledge from the all, but practically speaking, you have to discuss your to make the process of the patient. That's what discuss if it is going to be a planned or even if it's not planned, if you have a team of prosthetics are already there doing that. But to ask them whether their process are going to be entertaining or side. The process that they make that or it's going to be entertaining. This is part of the socket there probably. This is going to be hard. Then you can't give an entertaining star. Yes. You have to give side waiting, even if it is to be honest with them. But nowadays, what I'm not entering used to in the past. But nowadays, it is more side way. The end is softer. The end is softer and the side is where the most weight is for. Because what they found is that the process, because the end being the entire weight is on the single point. There is scar and the bone start projecting and the pain and all this. Right. So now they're making it sideways. So then you have to give incident because side the incident in that side will be exactly on the start. That has to be discussed with the this is a critical point. For example, you can say another important is also very important very discussing the constant pain will be very sensitive. Or you have to pull sharp knife, internet and filter, or you can do it just after bury into the as much as you can do it, but you can't get very night in the muscle. So it doesn't come in full star. It's start that. And another point for the competition is the contractor. That is very common because that is because of wrong or because of wrong plastic. Why does man what is plastic? What is plastic?
Muzzle with the fascia will approximate. Muzzle with the muzzle. That is, if it is more, it will slide whenever we apply the process.
About sliding, fibers get stuck. But when it is not in your body, the flexor and extended power. They're not of the same power. So they will get imbalanced power. So then they will start having the contracts. For that. that is cannot, if you approximate both sides in the midline, one will have more power.
Yes, sir.
So patient develop that power. So that is not dependent on one plus is not dependent. Again, it's equal to
Boom.
the paralysis. And so it's equal to that is fine. They lack of their own weight in the blood. So apple instead of minus. So that extra contraction has become very important. Because we don't see all the patients will be like this one. Will never be straight. They are always one
Yes, yes.
system in lecture. That is the very common complication. That is the more visible. And being the contract and all of their things maybe someone
Sir?
Late runner. You know who's the late runner? Have you heard of the late runner?
Yes.
After these 2 years, we had I did government education.
Yes, sir.
We had
Play like.
yeah.
I see.
We had together grades for classes. Either it's for that.
Yes, sir.
They use compete against the people and win.
Running, yes.
Running. Anyone disqualified for the student for the sake of that kind of process. Because of that grades of kind of
Yes, sir.
only one comes with the reason. So they have a really high possibility. Yeah, that was very so they have a thing like Sunday.
Yes, sir.
So rest of the side they don't know. So those are all industrial processes. Also integrated processes. So processes can be on top or also integrated.
Into the boom.
After integrated process, what we do is that we consider the level, the finger, the knee. So once start the engine is reopened, and then we plant a socket into the bone. The remaining process is magnetic. The one socket will be permanently implanted into the bone. That will be outside visible. The skin socket will be magnetic. Upper process can just stuck on that. But that generally works only in the upper end because in the weight plate, those magnetic systems don't work in the bone. So once we do it for works better when the patient is a child. Better than the child. Very expensive immunity something and but the patient is child, they learn that adapt very quickly. Very quickly. So that is I'm not saying that. Other thing,
Yes, sir. The tumors will require a margin.
again, for your question for the exam level, but then nowadays for all options are amputation is no longer being done. It's they try to solve it in the as much as possible. In some surgery, as we go forward with the future, everything all this surgery reduce and all conservative surgery, then people will be so we are trying to even try to implant a make balance also. So when it comes to operation of renal or not to be another, we don't plan to do something. If possible, there is an expert who don't do that. So it's called a Capana statement, where the entire it is sent for radiation on the patient is on the patient is transferred, and entire tumor is removed. It's sent for radiation. The part is radiated and not back. So that now that wound is completely dead, we have high dose radiation, no marrow, nothing. The bone is entirely dead. It is just like a scaffold. So that bone is prepared, then we take a piece of blood. We take a blood and insert inside the blood. Then we create a new marrow. And that describes the existing. So that is the link and solve. It has a very high rate of complication. We are still very minimum of technique. We have done applications and we are doing well. Complication related issues because the entire together technical. So basically, osteoarthritis is also very high. Well, infection and the entire antibiotic that and once you go to the we have something application is a very radical police. No return from I don't think